Hi, I'm Dr. Marla Shapiro. I'm a past president of the North American Menopause Society and a member of the boards of trustees. And I am thrilled today to be joined by Dr. Sharon Parrish. Sharon, tell everybody who you are and what you do.
So thank you for this opportunity. My name is Dr. Sharon Parrish. I'm an internal medicine, menopause, and women's health specialist, and I focus on sexual concerns in women in my practice. I'm a professor of clinical medicine and a professor of medicine and clinical psychiatry at the Weill Cornell Medical College in New York City.
Okay, so sexual health. For many healthcare providers, this is something that is not specifically screened for. So what are some of the common sexual concerns as we as healthcare providers taking care of midlife women should be bringing to the conversation?
Right, so when we're talking about midlife women, there are changes in sexual function that are process that occur from the late reproductive age through the menopausal transition into the postmenopausal years. Women may notice vaginal dryness, changes in lubrication, which may cause dyspareunia or pain during sexual activity, and that may become progressive as hormonal levels change in the vaginal vulvar area. Other changes that are associated with midlife hormonal causes, psychosocial causes, may include problems with desire, changes in their libido, diminished arousal, muted or loss of orgasm. And these problems may be interrelated. So you sort of have to find out kind of what came first when you're talking with patients.
So what are some of the tools that healthcare providers who are not necessarily trained in this area or may have the most comfort level in this area, what are some of the tools that they can use?
So one of the most important recommendations I have is just to ask, right? Is to develop a single or a couple of easy open-ended questions that you can ask your patients.
Such as?
So one thing is just to think of like sort of the progressive level of sort of sensitivity in starting with, how are things going in your relationship? What's that relationship like? Are you in a sexual relationship? How's that going? Do you have any concerns about your sexual function you'd like to discuss? Or a more tailored approach is to use something I call the ubiquity statement, right? And I think this is probably one of the most helpful things that I've learned, is to frame it in the context of the person's situation. So if someone is starting to have hot flashes, or starting to notice other changes with menopause, sleep, use a ubiquity statement like, many women as they become perimenopausal start to notice changes in their sexual function, sometimes vaginal dryness, sometimes pain with sexual activity. How about you? So you frame it in their group and then you ask an open-ended question, how about you? And so it lets them feel that it's common, it's kind of like a normal expectation to talk about it, it's normal that it might occur for them. And then it kind of opens the door.
I think many healthcare providers are not sure when to ask this, or many of them feel like it's opening Pandora's box. I don't have the time when I'm thinking about all the other screening things that I'm doing when you come in. Is that an issue?
Right, so I think that definitely clinicians are worried about this. I think it's good to figure this out kind of in your practice. Are you going to do it if you're a gynecologist at their time of their annual exam? If I'm an internist, so when I have sort of times in the care of a patient that I do screening, so it's the day I'm going to talk about their mammogram, their colonoscopy, this is their GYN, that's when I'm going to ask questions about sexual health. Or sexual concerns, or if they come in for a complaint like a UTI, that's a good trigger, something in the GU tract. So that's one thing, when to bring it up. The question is, Pandora's box. So I think one thing that's important is getting it out there, letting the patient tell you about it, validating it, and letting them know that you heard it, and then figuring out if you have time to handle it, or if you feel like you're comfortable handling it, or identifying and understanding where you might refer.
I think the most important thing that you've just said to healthcare providers is not to get into this cycle of don't ask, don't tell. Because often if we don't ask, a patient assumes there's nothing to do about this, so they don't tell.
Exactly, and there's actually studies, a number of studies that show patients are the ones that, if it gets discussed, more commonly bring it up, and they would much have been preferred to have been asked. They want their providers to bring it up. They want the green light that it's okay to talk about it.
Now, if the least you do is normalize it, bring it up, but at the same time feel, I don't have the tools to deal with this or the expertise. Where do you turn as a healthcare provider?
Right, so I have kind of an algorithm or a little stepwise idea. You know, you screen, you identify it, you empathically witness it or reflect it back. I heard what is going on with you. You reframe it as something worthy of attention, and then you either manage or refer. So where do you refer? So there are, you know, I think it depends, of course, on where your practice is and who your colleagues are, but in general, some gynecologists or sexual medicine specialists handle this. It might be a psychotherapist or a sex therapist. There are physical therapists who deal with sexual pain, who specifically do pelvic floor physical therapy, and so forth. And there are organizations that have Find the Provider websites, like NAMS, International Society for the Study of Women's Sexual Health, has a Find the Provider website. The physical therapy organizations and the sex therapy organizations also have Find the Provider websites.
So I think the most important message I'm taking away from here is include this as part of your history taking, include this as part of your physical exam, normalize this for women, either be comfortable treating it yourself or get more training to treat it yourself, but don't fall into that, let's not even go there.
No, absolutely. So, you know, focus on identification, connecting with the patient around this, normalizing and universalizing or ubiquitizing this. This is common for all women. And then really learning you can learn a few basic skills. And once you start to get a little bit of training, you realize there are some really basic skills in the most common areas that we can all manage ourselves, and some very straightforward office-based counseling. And it doesn't take a lot to learn where to refer people in your community.
I think it's so important for us to be aware of this and open our opportunity to be able to extend this provision of care, which is so critical to midlife women.
So they're so grateful. You know, when people come to see me and I bring it, they're like, oh, thank you. You know, really, really important for women. They're keeping vital, the maintenance of this area of their sexuality, their relationships. It speaks to everything about who they want to become as they transition through midlife. They want to stay vibrant, alive, connected. And they're so grateful if their doctor understands that and prioritizes it, or their clinician.
Such important messaging. Thank you so much.
You're welcome.